Hello, and welcome to this RPTH Research Recap, where we dive a little deeper into the science being published in RPTH. My name is Sueli Rezende, and I am one of the associate editors of the RPTH Journal. I am a medical doctor with residence in hematology and with a special interest in thrombosis and hemostasis. Currently, I work as a professor of internal medicine at Federal University of Minas Gerais in Brazil. I'm very pleased to introduce Amanda Stahl. Amanda is a clinical social worker. She has been working with adult patients at the Boston Hemophilia Center since 2015. In 2021, she won the Social Work Excellence Award through the National Bleeding Disorders Foundation for her research on post-traumatic stress disorders in people with hemophilia. Amanda has recently published with her co-workers a paper in RPTH entitled Post-Traumatic Stress Disorder and Post-Traumatic Stress Symptoms among Adults with Hemophilia A and B. This is a very important study because it revealed for the first time that about 12% of individuals with hemophilia met criteria for provisional diagnosis of post-traumatic stress disorders. For now, I will invite Amanda Stahl to tell us a little bit about this work and the implications of her findings for the individuals with hemophilia. For the ones who are joining us on Facebook, Twitter X, and YouTube, please leave your comments below, which will be answered during the discussion. Amanda, we look forward to hearing your presentation. Thanks very much for joining us in this RPTH recap.
Yeah, thank you so much, Zuli, for that introduction, and thank you for having me present today on our research on post-traumatic stress disorder and post-traumatic stress symptoms. And I am presenting today on behalf of my co-authors who are listed here. I thought I would just open this discussion with a quick overview of PTSD because you might be wondering what it has to do with bleeding disorders. So historically, PTSD has been associated with veterans or war combat or a single event like a car accident that happened in the past. But there's been more and more research exposing the impact of trauma in the setting of a chronic illness or acute medical condition in recent years. So what is PTSD? It is a stress-related psychiatric disorder characterized by symptoms of intrusion, avoidance, negative mood, and hyperarousal as a result of a traumatic life experience. And for a person with hemophilia, trauma may manifest differently than it would for someone who experienced a traumatic single event in the past. And these are some symptoms or behaviors that we've noticed in clinics and inspired us to research this topic. And what makes medical trauma unique is that for someone living with a chronic illness, the threat or reminder of the trauma can be ongoing. To put our research in perspective, I wanted to give some context with these statistics. Between 4 and 8% of people experience PTSD throughout their lives, and about 3 to 4% experience PTSD at any point in time. Our study looked at PTSD at any point in time. PTSD occurs in about 12 to 25% of survivors of acute life-threatening medical events like heart attack, stroke, or cancer, and approximately 15 to 35% of patients with chronic pain also experience PTSD. Some additional background and risk factors of PTSD for those with hemophilia. There has been a lot of research which has shown that individuals with hemophilia are at increased risk of developing other mental health conditions, including depression, anxiety, depression and anxiety, ADHD. And past studies have shown that health-related quality of life is negatively impacted by specific events related to hemophilia, including hepatitis, disability, acute bleeds, and arthropathy. From this study, we wanted to categorize and describe the emotional burden of medical trauma specific to people with hemophilia and better understand its overall impact so that we can hopefully try to prevent or treat it. So our research aims were to explore the prevalence of post-traumatic stress disorder and post-traumatic stress symptoms in adults with hemophilia A and B, and to characterize the trauma reported by the participants. Here are our methods. So participant eligibility, our study was conducted at 3 hemophilia treatment centers, all adults with hemophilia A and B of all severities at the Boston Hemophilia Center, the Mount Sinai Hemophilia Center in New York City, and the M Health Fairview Center for Bleeding and Clotting Disorders in Minnesota were eligible to participate. Using REDCap, we developed an online survey tool that was discussed at the time of the patient's annual comprehensive visit to their hemophilia treatment center, and the patient then self-administered the tool, which contains study consent. In the survey tool, participants were asked to provide demographic and clinical information, and then they were asked to indicate whether they had ever experienced a traumatic event related to their hemophilia. They were then asked to provide a brief narrative describing the traumatic experience and estimate when it had occurred. Participants were asked to complete a validated questionnaire containing the PTSD checklist for the DSM-5, which is known as the PCL-5, and it is a 20-question Likert survey used to assess the presence and severity of trauma symptoms related to the identified trauma. And the PCL-5 is a PTSD screening tool. It's not a standalone diagnostic tool, and we used it here to determine a positive PTSD screen and also assess trauma symptoms within just the last month. It's hard to see, but this is what the PCL-5 looked like. I'll talk about how it's scored on the next slide, but it evaluates each symptom cluster of PTSD, so intrusion, avoidance, negative alterations in cognition and mood, and arousal symptoms, and it also evaluates overall trauma symptom burden. So in this study, we were evaluating prevalence of both PTSD and clinically significant trauma symptoms like avoidance intrusion and what I had just mentioned, otherwise known as PTSS. And we did this to better understand the specific impact of trauma in hemophilia and how to determine potential intervention. Like, for example, if many patients screened high on the avoidance scale, we would have that data to evaluate and think about how we could intervene as providers to address the manifestations of avoidance, like are patients not showing up to a visit, are they not taking their medications, et cetera. So the PCL-5 can be scored 2 ways: by first summarizing the total and utilizing a cutoff score. And we use 31 for PTSD, which is indicated by the tool guidelines. It can also be scored by symptom cluster. So if participants reported a trauma and then met criteria for each symptom cluster, a positive PTSD screen was indicated. And if a participant reported trauma and met criteria for at least one symptom cluster, PTSS was indicated. Qualitative methods were used to categorize traumatic experiences identified among the participants. The experience of trauma is subjective, and we utilized inductive coding to analyze the narratives of trauma descriptions. When 5 main sources or themes of trauma emerged within the coding, we evaluated the nature of the occurrence, including whether the trauma was described as chronic versus a one-time event, as well as the timeline and when the trauma either started or occurred in the past. Here are some of our results, the demographics of participants. 178 patients participated across the 3 hemophilia treatment centers. This represented a 70% response rate. Most participants were male, and 45.5% had completed college. This slide explains some clinical characteristics of participants, and you'll see here that 101, which is more than half of the participants, indicated that they had experienced a traumatic event related to their hemophilia at some point throughout their life. And here are the results of the screening for PTSD. So 11.8% of participants screened positive for PTSD using both of the scoring methodologies that I had described. And 14% of participants with severe hemophilia A or B screened positive, which fits within the 12 to 25% of other disease groups like cardiac disease or stroke or cancer. 63 or 35.5% of participants endorsed at least one post-traumatic stress symptom, and intrusion symptoms were identified most frequently by participants. Multivariable analysis showed higher odds of a positive PTSD screen in participants with non-infectious comorbidities, infectious comorbidities, both infectious and non-infectious comorbidities together, and greater than one established mental health comorbidity. Reduced odds of a positive PTSD screen were seen in participants who had an older age 46 plus, and who had higher education levels. And here is some data regarding our qualitative analysis. The following 5 themes emerged from participants' subjective trauma descriptions. For more than half of participants who identified trauma, more than one theme was represented in their trauma description. Non-infectious medical events like a bleed or an injury were identified most frequently by participants. This slide highlights the complexity of trauma for participants who identified a traumatic event related to their hemophilia, and also for those who screened positive for PTSD, in terms of the trauma's genesis and duration. For both groups, traumatic events are rarely a single occurrence. One example of this is a participant reporting every bleed I've ever had as their traumatic event. And we learn that more often than not, trauma stems from multiple sources and is more likely to occur or begin during childhood. And 19 participants did not specify trauma onset or duration, but rather made statements such as my whole life. Our study had some limitations, which included first pain. So events like bleeding, surgeries, hemorrhages, et cetera, that were described in trauma descriptions could be painful or likely to cause pain. But if the participant did not cite pain specifically in their trauma description, our inductive coding excluded the opportunity for clarification. Our research was also conducted during the global COVID-19 pandemic, and so it's unknown how much COVID-19 may have impacted either the response rate or symptom burden. The key takeaway from our studies are as follows. So PTSD and PTSS are prevalent among adults with hemophilia. The majority of individuals with hemophilia can identify a traumatic event related to their hemophilia, and more than 1/3 go on to experience clinically significant trauma symptoms. And the prevalence of PTSD among those with hemophilia is roughly 3 times higher than the rate of PTSD experienced in the general population at any given point in time, which is, again, 3 to 4%. 2, trauma is complex for those with hemophilia, both in terms of when it began, as well as the recurring nature of how it is experienced, et cetera. 3, PTSD is more likely to occur in patients with medical comorbidities, with mental health comorbidities, who are younger than 46 and who have less education. This helps us understand who should be screened for PTSD and PTSS, and also exposes the vulnerability of young people with less education who also have comorbidities to PTSD. And finally, hemophilia trauma is almost always associated with the medical system. 92% of participants who reported a traumatic event indicated that indicated some sort of traumatic event which required some level of medical attention, intervention, or interaction with their medical provider. And because hemophilia requires patients to be dependent on the medical system, medical providers should recognize that patients may be experiencing a traumatic event while under their care. And providers should also recognize that when a patient doesn't come to their clinic visit or is a last-minute no-show, it might be because interfacing with the medical system has been traumatic for them in the past, and patients may not even be aware of their own automatic responses to the reminder of trauma. It's also plausible that some patients were avoiding the medical system by not participating in the study, or may have missed their clinic visit and missed the opportunity to participate. And we suspect that with a higher response rate, PTSD and trauma symptom rates may be higher. Our findings support the need for improvements in education regarding the nature of complex trauma within the hemophilia population for all members of the multidisciplinary healthcare team, and better education regarding trauma-informed care techniques and trauma prevention strategies. So trauma-informed care, meaning increased mutual decision-making, et cetera, has the potential to validate patient experiences, improve patient engagement, treatment adherence, and health outcomes. So that is my presentation. Thank you so much.
This is great, Amanda. Thanks very much for your presentation. Very nice. Well, I have some questions for you, and maybe others that are watching us maybe have questions as well. If you do, please place your questions on your screen, and we'll have it with us soon. Well, for the time being, One of my questions is that you mentioned the importance of trauma-informed care. Can you talk a little bit more about what that might look like?
Yeah, sure. So, the goal of trauma-informed care is to recognize that trauma is prevalent, among patients that we see, whether related to hemophilia or otherwise. And it's the goal is to try to prevent re-traumatization. And so I had mentioned mutual decision making, but it can also be done by just promoting a culture of safety within our clinics, asking permission, when we are intervening with a patient, giving choices when we can, making sure we're introducing ourselves, and being kind and generous, considering the environment. Where are you sitting in relationship to your patients? Inviting their questions, encouraging their questions, and creating clear expectations and predictability. And trying to minimize the power differential as best as possible. So there are lots of ways to kind of go about that to prevent future traumatic experiences. Also incorporating, psychosocial providers within clinics. I know most hemophilia treatment centers do have social workers embedded in the clinic, so that also can be helpful. I know some pediatric clinics utilize child life specialists who help with infusions, and that can be a good way to intervene early and prevent trauma from occurring.
That's great. Thank you. And I mean, you have your study, you have your results, and I was curious to know that what have you done with your results, with your what has been the impact of this study in your patients, for your practice? So you identified that nearly 12% of your patients have PTSD. And then what do you do with this information in the clinical practice?
Yeah, I mean, I think it calls for screening in general, more trauma screening among other, in all clinic spaces. The PCL5 is a really easy tool to use if you have a psychosocial provider to screen for trauma symptoms that are happening in clinics. For me personally, it's opened up a lot of really great conversations that I've had with patients. I've heard from patients that it's been really validating for them to hear, this may not be depression or anxiety. It might be because I've had this lifelong chronic condition that's been really challenging to navigate. That's been hard for my family. And now they're finally like, oh, this is trauma. And it really shifts kind of the perspective of like, what's wrong with me to what happened to me. And I think that is a really different outlook to have when they've had such traumatic experiences related to their disease. And I think that, some of our patients, have a lot of other anxiety and maybe didn't even realize kind of how much their day-to-day anxiety has to do with having this bleeding disorder. They're constantly like having to be on the lookout for danger or the threat of what's going on. And, also their parenting techniques. We have a lot of patients who grew up having hemophilia and now have little kids and are kind of like re-experiencing their childhood through their children who may or may not have hemophilia, and what that's like for them. So it's opened up a lot of conversations, and I think screening for trauma in general can help your social work practice, and get to know your patients even on a much deeper level.
But would you refer those patients with PTSD for counseling or
Mm-hmm.
for a specific treatment, or
Yeah, I mean,
how
it
shall you
depends.
handle?
Yeah, it depends on, how much the trauma is impacting them. I mean, some patients, have social workers in clinics, and that can be enough. Some patients do seek outside counseling. There is a specific trauma therapy called cognitive processing therapy. So if
Mhm.
someone is experiencing trauma, cognitive processing therapy is just one way to kind of intervene. And when someone experiences trauma, they kind of tell stories to themselves about themselves, right? So like if you have hemophilia, the story might be, I'm bad, or the world is dangerous and I'm a bad person in that world. Or maybe not also, but if it is, one way to cope with that is to kind of learn how to tell yourself, a different story about your life and situations that you can more easily cope with and grapple with. So anyway, cognitive processing therapy kind of helps patients navigate that.
Okay, great. Well, I have some more questions. When I read your study, I was thinking about the the patients who had less PTSD. So you identified the two factors that are associated with that. So
Mhm.
one was the age above 46 years old, and the other one was a higher education level. So what I was wondering is that, I mean, in 2015, the Office for National Statistics from the UK reported a happiness U-shape according to age. So they showed that adults were mostly unhappy when they were between 25 and 45 years old, and that the average happiness became steadily greater from 45 until they reached about 70, when unhappiness started to rise again. So I was wondering if you found a similar kind of a trend in your work. Do you think it has to do with happiness, or at this age, or what happened that maybe those patients, older patients, felt, I mean, were less associated with PTSD for
Yeah,
you?
I think that's a great question, and I love that study. I think it's a really valuable one to have, and I think that as we age, I mean, there's a variety of factors. We're more settled, maybe in our career and our family. So there's a lot of things happening, and I wonder with patients who have hemophilia if it's just something that they now have accepted and understand how to manage. And so it just kind of like anything else, they've just developed a maturity and ability to accept what's happening in their lives. So I think that it probably does correlate with happiness to some degree. And I think, happiness stems from just kind of overall like satisfaction with maybe decisions we've made, or just, like acceptance of where we are in our lives. So I definitely think that is a valuable research to put this into perspective.
Good. And the other point is about education, because
Mhm.
this associated as well as a less PTSD in your work. So you did not collect information on for this person, but you collect educational level. Do you think that the high education could be a proxy for income in this population? That's why it's less association with PTSD.
Potentially, yeah. I think that for sure could contribute to it. Um, Higher education, I know other studies who look at mental health in other disease groups, like even anxiety or depression, have also similarly found that education has been a protective factor. Employment, and I think we did look at employment, and that was not associated with either protection or increased levels of PTSD. So, employment also could potentially be a proxy for income. But yeah, I mean, it's something to consider. I know that education and employment usually are associated with kind of like a lower reduced risk of other mental health conditions.
And also because when we think about health, it has costs. And maybe if you think that someone have more income and
Mhm.
they can get a better health care, and maybe they are, I mean, more well cared, and then PTSD could decrease. So it's just maybe they are all related in all these senses, that I think it could a nice thing to explore
Yeah,
further in your study.
absolutely. I agree.
Yeah. Okay, so what else should we talk about? Are there any follow-up studies you might conduct on PTSD, or with this study to further explore this in your setting, in your hospital?
Yeah, I mean, I think I would probably apply this to other bleeding disorders. Just, me personally, I only work with patients who have bleeding disorders. And so in VWD, I know that they did a big study recently on prevalence of depression and anxiety. And I don't think trauma was included in that study, but I definitely think it could be. And I would be curious to know more about that. I think also, pain, again, it was sort of a limitation in our study because we didn't really look at pain and PTSD, the connection between the two. And pain is so hard to manage and reminds us of whatever causes the pain all the time. So I do think that those two things are really closely linked, and our study kind of missed the mark on really exploring the pain PTSD relationship. And I wish that we had been able to go deeper in that. And I think there's a lot more opportunity to explore that in other studies.
Yeah, and I wonder whether these, well, your findings might change with the better hemophilia care that is going to happen in, well, it's happening now, but in the next years, because we have now the non-factor therapies and patients bleed less with the therapies. We will have the gene therapy coming now soon, and patient will bleed less. Therefore, they will have less pain. And maybe if pain is related to your results, maybe and bleeding, maybe you can have a decrease on PTSD. Do you think this might happen?
I would be curious if it would happen. I guess when I first started this study, I thought we would have a lot more. I was thinking about infectious disease and the blood contamination of the 80s and our patients, who continue to live with HIV. And that's sort of like the genesis of this project. But, I really found that PTSD was prevalent in our younger population, who didn't have HIV or any sort of infectious disease. So I don't know. And I think you could repeat this like in 10 years, right? With the advent of other therapies that may prevent bleeding earlier. So it could be interesting to see if it changes over the years. And I hope it does. I hope it decreases.
Yeah, I mean, very exciting to think about all those reasons to maybe to decrease the PTSD and follow this up in few years' time. I think it's a very good idea as well.
Yeah.
Okay. Well, I think we're done, and it has been great to talk to you, Amanda. And I'm very pleased to read your work and to see these results. And it's maybe a new place of work in the hemophilia. And let's see how it comes in your further studies as well. I thank you very much, and I thank RPTH for giving me the opportunity to talk to you here. Thank you. Thanks
Thank you so
all
much.
who are watching us as well.